Well, good afternoon, everyone. Really glad to have you all here. Is everybody having a good conference so far? Awesome. Great, great. Well, I am Dr. Brian McGregor. I'm one of the co-investigators here at the center. I lead the cross-cutting area of criminal justice and health, and I have the pleasure of moderating this session today. We have a single presenter for this session, Dr. Lynda Gibson, who is Director of Psychological Services Center at the University of Illinois-Champaign. I'll share a few more details about Dr. Gibson. She is also the Program Director for the Safe First Steps Program, an early intervention research program designed to support providers in addressing the wide-ranging impact of childhood exposure to trauma and community violence. And so today she's going to share a bit about her work. The title of her presentation is Safe First Steps, a community-based approach to supporting families exposed to trauma and violence. She's going to present until around 2:30. We want to protect about 10 to 15 minutes for some questions and answers that I know you all will have. And so really glad to have you here. I'm glad you all are sitting closer to the front than the back, because we do expect folks to be finishing up lunch and coming on in. So without further ado, I'll pass it over to Dr. Gibson.
Okay, thank you, Dr. McGregor. Hopefully everyone can hear me. Fine, okay. As Dr. McGregor mentioned, my name is Dr. Lynda Gibson. I am a clinical child psychologist, specializing particularly in pediatric trauma exposure and working with children and adolescents that have general trauma exposure as well as exposure to community violence. And so today I will be talking about the Safe First Steps program. I'm honored to speak with you all today about this program that I developed about 4 or 5 years ago, specifically due to the rise in community violence exposure that we were seeing within the city of Chicago and surrounding areas, as well as the rate of intergenerational trauma that a lot of our families were experiencing and their inability to provide support for their own children and families. And so the Safe First Steps takes a systems of care perspective or framework in which we're training all of the individuals within a child system of care on being more trauma informed, being able to recognize signs that our children and adolescents are being exposed to trauma, and then being able to connect them to resources. And we use a prevention-based framework in which we're specifically targeting early childhood populations and working with preschools and Head Start centers right now in the state of Illinois to help agencies be more trauma informed. So the key objectives of today's presentation, I'm going to talk a lot about the implementation and application of strategies that can assist or provide strategies in assisting families with trauma exposure. Just giving you all first a little background information regarding the effects of trauma, the long-term impact of trauma, and how there's this really big gap in terms of services that have been developed for younger children. And so that's the primary goal of our program, is that early intervention work. So what do we actually know about childhood trauma exposure and looking at the impact of community violence exposure? And when I talk about trauma, I'm talking about those situations or events that could be one time or happening long term. So chronic or complex trauma exposure, which is more common within Black and Brown children and families, in those situations in which an event happens and it causes a child to feel that there's a constant or ongoing threat to their safety. And we're looking specifically at the impact of trauma within our under-resourced communities, within our Black and Brown families, and that pattern in which we see early signs of PTSD in our preschool children and our kids that are even in Head Start. And then there's this long-term trickle effect in which the symptoms associated with trauma exposure tend to increase in severity as well as in frequency over time when there's an absence of intervention. And kind of looking at a theoretical framework, we rely a lot on Bronfenbrenner's ecological model and a lot of ecological theories that have been adapted for the Black community in particular to have a greater understanding of to what degree are the risk factors within Black families increasing the negative developmental outcomes for children. So what do we actually know? So kind of the little bit of research that's been done looking at the impact of trauma exposure for early childhood development, we know that it's associated with negative effects in terms of behavioral, psychosocial functioning, as well as cognitive functioning. And so a lot of our work with schools in particular is at looking at how trauma exposure impacts academic performance and cognitive development, and what strategies can we implement in the classroom to help children be more successful across these different areas. And then we also focus on the parenting piece. So one of the big things that we know is that in the families that we work with, when there is this presence of intergenerational trauma, it decreases the likelihood that our parents can provide the necessary support that the children need. And so we do a lot of work looking at what is the degree of intergenerational trauma or cycles of trauma and violence occurring within families, and how can we provide intervention and support for children as well as their caregivers. And then looking specifically at community violence exposure, as I mentioned, we have all of these different types of trauma exposure, such as abuse, neglect, homelessness, and then there's community violence exposure. One of the reasons that I do a lot of work in that area in particular is because the symptoms and the severity of those symptoms look much different than some of our other types of trauma. So in particular, when we look at community violence exposure for children in early childhood, the current prevalence rates are around 60 to 80% of those kids that live in cities such as Chicago are exposed to trauma by the age of 5. A lot of times that's witness trauma, but it's also direct trauma exposure to community violence. And so we know that there's this major public health concern in which a lot of our younger children, and specifically our Black children, are being exposed to community violence, but there's not the implementation of services to support that exposure. And then one of the things that we also wanted to look at when we first began to explore community violence exposure is, why was there this big gap or lack of understanding in how community violence exposure was impacting Black and Brown children? And what we actually found is that there wasn't a really good way of assessing the impact of community violence exposure. So there's a lot of different studies and programs that take a retrospective approach in which they're looking at the long-term impact. And so they'll do survey assessments for adolescents and adults and figure out, okay, if you were exposed to community violence when you were younger, how did that impact your development? The approach that we wanted to take is to be able to look at this as it was happening in real time and see what was the connection between community violence exposure and symptoms of psychopathology. And so that was the main framework or focus of developing the Safe First Steps program, is really being able to understand how is community violence and exposure impacting children in early childhood, and what were the different support services that we could put in place to address those challenges. So here to give you all just a general idea of what was going on in the city of Chicago when I first created this program, again, between the period of 2019 to 2021, we saw a drastic increase, not only in community violence exposure, but in particular, community violence exposure impacting young children of color and Black children in particular. As you can see, these are just a few of the headlines from 2018, 2019, and 2020, in which multiple children, including children that were in our Head Start centers, that were in preschool, that were in elementary school, had either been victims of gun violence and community violence exposure, or they were witnesses to these events that were occurring. And so today I'm going to take time to briefly explain to you all the 3 tiers of the Safe First Steps program. So again, when I first created this program, it was to be able to have a full understanding or a better understanding of how community violence exposure was impacting children. And so being within an academic setting, of course, we started with the research and the assessment piece. And then we added a second tier in which we wanted to look at training and implementation. So once we have this understanding of the needs of the families, then what can we do? And so that's the training and implementation portion. And then last is intervention. So we have the research, we have the assessment model, we're training the teachers, but the family still needed services. And so that's that last piece, is being able to create a program that families would be able to utilize in order to support the children and the parents. So just really quickly introducing my pilot team for the Safe First Steps program and acknowledging their contributions to the 3 different projects that are under this program. Dr. Mayra Guyona, who is a psychologist, a school psychologist in particular, and our lead trainer for our Spanish-speaking families that we work with in our schools that are predominantly Spanish-speaking. Dr. Jalil Abdul-Adil and Dr. Lisa Suarez, who are both clinical child psychologists and do a lot of work related to child and adolescent trauma. And then Dr. King and Dr. Minez, who are our primary consultants. And so it was really important when I developed this program to make sure that we had a team of people who were representative of the populations or the demographics that we were working with. These are also people who all have doctorates in specifically in community violence and trauma exposure within communities of color. Similar to our list of research assistants here, we have a large team of research assistants from doctoral programs across the city of Chicago and the wider state of Illinois, who do a lot of work to support our parents in particular. So again, all of the services that we are offering within this model are available to providers, but then we also do a lot of family-based work. So first, giving an overview of the Preschool Community Violence Awareness Project. Again, the purpose of this project was to be able to look at the impact or the prevalence of community violence exposure. This project was done in partnership with the Illinois Head Start Association, the Centers for New Horizons, and 2 locations for the Chicago Child Care Society in Hyde Park, which is one of the more affluent areas in Chicago, and Inglewood, which is one of the most crime-ridden areas in the city of Chicago. And so I've talked already about the purpose. So the purpose of this study was to be able to look at community violence exposure as it was happening in real time and co-occurring symptoms of psychopathology. So we wanted to be able to look at 32 or so different events of community violence exposure while also tracking internalizing and externalizing symptoms in preschool children. We did this using ecological momentary assessment and developing a program for families in which they would be able to use their cell phones to track violence exposure and symptoms of psychopathology as it was happening in real time. Again, this project was done over a 2-year period in which we were really able to work with 32 different families to track that initial violence exposure. We asked questions about lifetime trauma exposure and community violence exposure. And then we also did follow-up in which we worked with these families to train all the teachers for the families, to train the providers within the Head Start Center, within the preschools, and then we also worked with the parents. So this image here gives you all an example of the graphics that they would see on their cell phone. So within the ecological momentary assessment, families were beat. They were asked to document the type of community violence exposure. We also asked them to document physical proximity and relational proximity. So who was involved in that event and where did it happen? We wanted to see if that would make a difference in the symptoms that we were seeing in these children. So to give you all an idea of our initial pilot sample, again, it was 32 families, mostly Black and brown children, kids who were in preschools across those 3 different partner sites. One of the really interesting things that we found when we first started working with the 32 pilot families was that, as you can see, 7 of those, the kids from those families had already been referred to mental health providers due to a significant severity of symptoms. However, none of them had actually been enrolled in any type of formal treatment. And then when we first did an initial assessment of lifetime exposure to community violence, 8 of the kids in our 32 families had either seen someone be shot or killed due to community violence exposure. Again, this is all by the age of 3 to 5. And although these kids had witnessed these types of trauma, none of them had ever been enrolled in any type of services. Similarly, when we worked with the 32 families, the majority of the parents were showing signs of significant clinical levels of psychopathology. So just looking at the areas that we worked with. So again, within the city of Chicago, it was really important for us to have a diverse sample and variability in terms of our levels of crime so that we will really be able to see to what degree is community violence exposure and crime having an impact on child development. And so we worked with the 3 different Head Start centers in areas that Chicago had identified as having low, medium, and high levels of crime. And that again will be able to allow us to see the connection between the violence exposure that was happening and those co-occurring symptoms. So what did we actually find? So in working with these 32 families over that period of 2 years, again, kind of looking at lifetime assessment or lifetime history first, what we found is that 75% of those kids have been either directly or indirectly exposed to community violence prior to working with our program, 56% of those kids were already exhibiting internalizing symptoms, and 63% of those children were exhibiting externalizing symptoms. This was really important because for a lot of the schools, they were not necessarily implementing programs focused on mental health, on behavior, and well-being. And so what this allowed us to do is to have conversations with the directors and the principals at the schools and the Head Start centers about what are some of the things that you all need to make change in terms of your programming and the services that are offered. In particular, adding more programs that focused on trauma recovery and resiliency. A few key other findings from our initial study. One of the key things being that in addition to internalizing and externalizing symptoms, a large majority of the kids between the ages of 3 to 5 were showing significant challenges related to their sleep routines as well as separation anxiety. As you can imagine, within a preschool or Head Start center, issues with sleep directly impacted a number of different things in terms of nap time within that setting, social interactions, the negative interactions with teachers. And so those were some of the things that we had not initially anticipated that we would be able to see those immediate changes or effects in such a short period of time. And so based on the information that we gathered from the Preschool Community Violence Awareness Project, we knew that there was a lot more that we would need to do to be able to support these children. So again, in addition to the work that we had planned to do with families, we knew that we needed to do more in terms of doing additional outreach to the different adults that were coming into contact with these families every day. And so this was the second tier of the Safe First Steps program that I created, which was the Early Childhood Training and Consultation Program. Again, the purpose of this program was to use a systems of care framework. So in addition to the work that we were doing with children and families, we added additional training and consultation in which we would work with the teachers, the counselors, the social workers, the directors, to really be able to make changes to overall programming within our Head Start centers, within our early childhood centers, and really be able to build in programming that would directly result in trauma recovery or help to support the children and the families who are experiencing challenges. So this is a quick look at some of our different partners that we've had. So we implemented the training and consultation program in 2022, and over the past 2 years have implemented this program with different partners, again, working primarily with Head Start centers within the city of Chicago, as well as daycare centers in surrounding areas, and then a few school districts to do work with their elementary schools. Again, first targeting that early childhood population. So what is actually included in the early childhood trauma and consultation program? So again, we wanted to make sure that in implementing this program and partnering with different organizations, that it wasn't this broad kind of program in which we weren't really able to support the organizations when we created a partnership. We wanted to make sure that we were doing everything that we could to support their implementation of more trauma-informed care and to be able to utilize strategies that could really support the children. So we created this wide framework in which we offered a number of different services and support. We did trauma-informed practices screenings. We reviewed handbooks to look at actual policies around mental health and trauma-informed care. In addition to our trainings, we required that all of our providers would create an action plan. We did consultation. We provided newsletters to our children, our families, our staff. We also gave SEL toolkits. So when we would do consultation and talk about what are the different tools or the materials that you could use to support these families, we wanted to make sure that those were available. And so we had grant funding to provide those to our centers. And then the family piece. So again, we wanted to make sure that in addition to training the Head Start teachers and the directors, that we were also supporting our parents. And so we did a lot of workshops with parents, and we also offered consultation to parents. And last, we participated in community resource fairs. So any of the fairs that were happening in the community, someone on my team would go to those and be able to share information about the impact of trauma exposure, the strategies that families could do, and then also help to directly connect families to therapeutic services. So as I mentioned, we did a trauma-informed practices screening in which we were able to work with each organization, each Head Start center, each preschool, to first be able to see to what degree are you all actually implementing trauma-informed practices. What this screening allowed us to do is it allowed us to create a plan for how we could really support the agency. And so those 6 principles that we utilized were based on SAMHSA's key principles of trauma-informed care. We first focused on safety, trustworthiness, and transparency, and peer support. Those were our first 3 areas that we wanted to look at with each individual agency. And in doing this screening, it allowed us to see what are the strengths within the agency. So we didn't want to come in using a deficits approach. We focused on the strengths first. What are they doing that's already working really well, and how can we utilize that to help them in supporting their children and families? And then we also looked at areas for growth. So in terms of trauma-informed practices or trauma-informed care, what did they need support with? And so as we identified different areas of growth within a Head Start center, for example, we would then create an action plan with their director for here are the different things that you can do to be more trauma-informed across these different areas. The other 3 areas were collaboration and mutuality, empowerment, voice and choice, and cultural, historical, and gender issues. Again, similar to those other areas, we worked with them to identify what are the things that you're doing well, and then what are the things that you can use assistance and support with. And then we would provide monthly consultation across all of these different areas. This slide here gives an overview of the different individuals who participated in our program for the past 2 years. So in addition to training organizations, I think in total that has worked with over 3,000 different children between the ages of 3 to 5. These are the specific providers or adults that we have worked with. One of the reasons that I think it's really important to always include this information is because I think it gives you an idea of the systems of care framework in which we're training all of the individuals that come into contact with these children, both at home as well as in their Head Start center or within their school. It was really important for us to not only train the teachers or the parents, for example, but also train someone such as the people that worked in the office. Those are the people who were answering the phones when the parents would call, or the security officer who would often be called to the room when a child was showing maladaptive behavior. We wanted to train our security officers on how can you implement the school's discipline policy, but do it in a restorative way? Or what are some more trauma-informed practices that you can put in place to help with de-escalation, for example? And then all of our mental health providers. So within our Head Start centers or our schools that we worked with, we did a lot of separate one-on-one consultation with the counselors, with the social workers, to help them figure out what are some of the things that are working really well in terms of the behavioral policies and the behavior plans that you all have within your center, and what are the ways that you can make adjustments so that they're more trauma-informed. And then, as I mentioned, every individual who participates in the Safe First Steps program develops a trauma-informed practices implementation plan. And so it's really important for us that after we do our initial trainings, that we work with Head Start centers, for example, to be able to come up with a plan for what can you actually do to implement these trauma-informed practices. So it's not enough to go into an agency or a center or a school and just say, here's the 6 key trauma-informed principles, this is what you should do. We worked with each individual that we trained to actually come up with a list of goals. How can you be more trauma-informed as a teacher in a Head Start classroom? Then we also talked about the challenges. What are some of the challenges that would actually prevent you from being successful in those goals? Based on the challenges that they identified, we would meet with that teacher monthly and provide consultation on how can we actually address those challenges. And then last was the connection to resources. So a big part of our action plan was helping our providers and a lot of our directors in particular to figure out what resources can our team provide in order to help your center be more successful. And so listed here is just a few examples of the different goals and the challenges that our providers or our teachers or our parents have mentioned over the past 2 years. One big thing was kind of the lack of overall awareness about the impact of trauma exposure. So in talking to a lot of our Head Start teachers in particular, they talked about the lack of understanding, overall understanding about the degree to which a lot of their families were experiencing different stressors or different types of hardship, and how that actually trickled into everyday interactions or things that were happening in the classroom. And so we did a lot of psychoeducation about that in particular. The other piece was just really being able to understand, how do we take the everyday things or the everyday programming that's being done in Head Start and adapt it to meet the needs of the Black and Brown families that were in those centers. So looking at current policies that have been developed for Head Start and figuring out how can we take a more culturally competent approach to make sure that we're implementing those strategies. And then this is the focus of our monthly consultation meeting. So again, in implementing the Safe First Steps program within different Head Start centers, we wanted to make sure we provided ongoing support for our teachers, for our directors, for our parents. So we did a lot of consultation, again, specifically on the things that we noticed were areas of growth, the things that came up throughout our partnership year, and then the things that would come up depending on events of trauma that were happening. So for example, with one of our partner sites, within one partner year, within one fiscal year, there were 3 parents that was shot and killed at that Head Start center. And so that completely shifted our partnership and the focus of our consultations, in which we did a lot of work specifically on traumatic grief, the loss of a parent, helping teachers to know, how do you actually support this kid who's 4 years old and doesn't have a clear understanding of death and what that looks like or what that means? And then how do you support the parent who just lost their partner, but is also trying to provide support for that kid? And so we would a lot of times shift the focus of our consultation just depending on the needs of the families at the center that we were working with. And so this gives you an end of year activity report. So over that 2-year period from May of 2022 to May of 2024, what did we actually do with our different partner sites? And so the things first listed here are the things that we had initially included when I developed this program. I said, these are the different things that we would need to do to make sure we can support these schools. And that was based on consultation with Head Start directors. So we had a team of people that really helped to inform this program development. It was based on a lot of research that had been done in terms of, what do you need to include for an agency to be trauma informed? And so we did all of those things that we actually needed to do. The big question that I always get is, so were you actually successful doing the exact things that you included in that initial model? And so I have the question here, was this enough to actually address the complex needs of staff, children, and families? The answer is no. So even with all of the different services that we were offering, that wasn't enough to actually meet the needs of these families. And so I have added here in purple all of the additional things that we did during this pilot period. And so I was fortunate to have a team of people who are very understanding in terms of the initial model that we're proposing when we're working with all of these partners may not be enough. So over this 2-year pilot period, what we're going to do is make adjustments or modifications to figure out what services actually work and where do we need to make additions. And so as you can see in purple, these are the things that we added to our model. So we worked with a lot of our Head Start centers to actually do classroom observations. So when the teachers would come to us in consultation, they would tell us what was going on, but they're like, you don't really understand if you don't see it. Or we would tell them something to do in the classroom, but then they wouldn't do it correctly. And so we actually took time to go into the Head Start centers, model the different trauma-informed practices that we were explaining, show them how can you actually recognize early on that this kid is having a bad day, they're dealing with trauma exposure, and help to de-escalate it. We also helped with a lot of outreach support to parents. So one of the big challenges that teachers would also often mention was, we actually don't know how to have a conversation with the parent about, hey, we're noticing this problem behavior, or we have these services available that you maybe could utilize. And so it was really important for a lot of our people at the Head Start centers to be able to have these conversations in a way where they could raise awareness to the parent about the needs of the kid without making the parent feel that they were a failure or that they were not doing the things that they should do as a parent. And so that was a big thing that we did with a lot of our Head Start teachers in particular, was actually make the outreach calls with them and kind of modeled, how do you have that initial conversation? The other thing that we added to this program was being able to provide individual and family therapy to the kids in our Head Start centers in our elementary schools. And so we wanted to make sure that we were providing a framework or modeling what those sessions should look like. And so, in offering individual and family therapy, we did that in collaboration with the mental health workers who were at those different sites. So, showing them how do you do short term therapy for a kid who just lost their parent? What approach do you take? What's the duration of those services like? And so these are just some of the things that we added to that initial model. These are a few pictures here of the different activities that we did. Again, doing a lot of training and consultation, doing a lot of activities within the classroom. So we would go into the classroom and model, how do you use music and dance as a therapeutic strategy? How do you do mindfulness activities or relaxation activities with a 3-year-old? What are some of the different books that you can read to kids that can help explain grief or loss? How can you work with a 3 or 4-year-old to be able to understand that even though they're saying they're angry, underneath that is confusion, feelings of unsafety? How do they actually communicate that to their teacher or their parent? And so then looking at program evaluation. So again, keeping in mind that this was done in partnership with the University of Illinois Urbana-Champaign. And so in addition to dissemination, we were also doing a lot of evaluation. So being able to see, is this program actually working? Is it effective? What are the outcomes or the results? And so these are just a few examples of some of the things that our providers mentioned. So the big thing being, of course, they were more mindful of the impact of trauma exposure. So I think that in particular was the overarching theme when we talked with our Head Start teachers, just being more mindful about the daily stressors that the kids were exposed to, gave them an entirely new way of thinking about the kids' experiences. I think they were more mindful of, what is this kid facing or experiencing before they walk in the door at 8 o'clock? And then how does that impact their behavior? How does that impact how they are at lunchtime, at nap time? And then also the inclusion of more restorative practices. So in particular, when we talked with our directors, with our security officers, with our deans at our elementary schools, they talked about modifications that they made to policies around discipline and restorative practices. Then another piece, an increase in parent partnerships and outreach to home. So that was one of the big successes that I would say we saw in our Head Start centers in particular, was they were more intentional about scheduling activities for parents and families, doing a lot more parent outreach, figuring out what are the best times of the day to be able to reach the most families. Why is it important to offer both in-person services as well as virtual services or workshops? And then I'll skip down to the last one there, the implementation of monthly self-care strategies for staff. That was the other really big thing that we focused on when we created this program, was being able to increase awareness about the presence of secondary traumatic stress. So if we're working in a Head Start center, for example, where we have 80 to 90% of our kids in the center with chronic community violence or trauma exposure, there's a very high likelihood that as a result of being a teacher, a director within that center, you're going to experience some type of secondary traumatic stress, meaning a lot of the symptoms associated with PTSD, maybe burnout, depression, anxiety, that automatically increases as a result of the population that you're working with. And so for a lot of our centers, we worked with the directors and the principals in particular on figuring out, how can we be more intentional about doing self-care activities for staff so that they are actually able to be in a place where they can provide support for the children and the families. And then just looking at the trauma-informed practices screening. So again, I mentioned that we would do this screening for every partner that we would work with, in which we really wanted to be able to see, to what degree are you all actually implementing trauma-informed care. And so we would have them do a pre-screening before training. So before we even started working with these centers, we would have them do a screening. And then they would do a screening immediately after the training, and then every 6 months after that for their initial 2 years that they partner with us. As you can see in the pre-screening, when we look at all of our partners together, what they said is that 68% of the time they were actually implementing these 6 trauma-informed principles. And then when we look at post-training, it jumps down to 56%. And so for us, it's actually good to see that decrease, because what that means is that they actually have a better understanding about what does it actually mean to be trauma informed. So for example, when we had them answer questions on safety, for example, they were reporting that they thought they were doing much better in terms of providing safety, providing a welcoming environment than they actually were. And so after they do our training, they have a better understanding and know, okay, maybe I'm not actually doing the best that I can in this area. And so that score dropped down to 56%. And then as you can see over time, that 6-month score went up to 63%. And then after working with our partner schools and Head Start centers for 2 years, that went up to 92%. So when we just did our assessment with all of our 2-year partners last month, they scored a 92% across the different partner organizations, meaning that 92% of the time, now all of the staff at that school are implementing trauma-informed practices. And then so overall recommendations. So just from implementing this program, what are some of the key things that we would say is most important? So this is something in terms of application that you all can say, okay, if I want to make sure that my agency or my organization is being trauma informed, what are some of the different things that I need to focus on? So organizational policies and procedures is one of the big ones. So in addition to a lot of the work that we were doing with entire staff members, we created separate consultations for directors or for principals, because we knew that they were the key people that would have a lot of decision-making abilities or powers related to organizational policies and practices. The other thing was standardized documentation. So a lot of times when we would do consultation sessions, teachers or parents would mention some of the challenges they were having with their children. But for our Head Start centers in particular, a lot of the teachers were not recording or really tracking the behaviors or the trauma symptoms that they were seeing. And so we helped them to create a behavior tracking plan, and that would allow us to know, okay, what are the symptoms that the kids are actually showing? What are the steps or the procedures that we're actually putting in place to provide support? And then what is the progress over time? And what that really allowed us to see or to know is at what point do we actually need to link these kids to services? So if a teacher, for example, is noticing, okay, all of a sudden this kid is showing problem behavior within the classroom, they're fighting, they're crying more often. We've tried to implement a behavioral plan. It's still not successful. We're seeing an increase in the severity of these symptoms, then that's when we would link them to additional support services. And then that last piece I'll mention is ongoing and consistent consultation. So when we partner with organizations specifically around training and consultation of trauma-informed care, the big thing that we would often hear our principals, our directors say at Head Start centers, at elementary schools, is that long-term, our staff are not able to maintain the policies or the practices that you all are saying, because you come in and do the training and then you disappear. And so it was really important for us to offer a long-term partnership in which we did that initial training, we did consultation every few months, and then we also did pre or post trainings in which we followed up and offered additional training and consultation. And so I think that's one of the reasons that we're really able to see that significant increase in use of trauma-informed practices, because we stayed with those organizations and consistently work with them to figure out what are some of the key areas of growth that you all need us to help support in order to be successful. And so then the last piece, the Child and Adolescent School Parent and Community Engagement Clinic. So again, I mentioned in the beginning that we wanted to create this 3-tier model in which we would first be able to do an assessment. We wanted to do the research to figure out what are the needs within this community, what's happening. And then we wanted to do the training and the consultation, so working with the providers. And then that 3rd tier is being able to provide direct support, mental health support and consultation for the parents and families that we work with. And so this is the next step in the Safe First Steps program. the space clinic or the school parent and community engagement clinic, again, keeping with our systems of care framework. So this is a clinic that I've recently developed a framework and model for that will be opening at the University of Illinois in August of this year. And we focus specifically on 5 key services. So the first is diagnostic evaluation. What makes the evaluation different and unique is that all of the assessments that we're using have been normed in working with African American families. And so we're making sure that all of the measures that we're using to do assessments are culturally competent or culturally relevant or sensitive. Likewise, we're doing individualized treatment planning. So working with each child or each family to be able to figure out what are the stressors and the trauma exposure within that individual family, and how can we create a treatment model that not only addresses the needs of the child, but also the parent. Third, individual, family, and group therapy. So again, we're not only focusing on the child or the individual, but we're making sure that we're providing therapy for the entire family. We're doing multifamily groups, and then we're also doing group therapy. So that is our plan in working with schools, is that for our Head Start centers in particular, we'll go into those centers and do group therapy for the children within the Head Start classrooms. And then fourth, parent training and family workshops. So again, in our work with parents, and we have a team of parents who have been on our focus groups as we work to develop this clinic, one of the big things that they often talk about is the impact of psychoeducation. So even when we did the Preschool Community Violence Awareness Project, we saw a decrease in trauma exposure just by talking to parents about what are the strategies that you can use to increase your child's safety. And so in doing a lot of parent training and family workshops, we're hoping that we'll be able to continue to increase parent engagement. We also want to focus on parent overall mental health and well-being. So that's the fourth component. And then the fifth component is school advocacy and collaboration. So we have a team of school psychologists who will be working in the clinic, who will be able to partner with our Head Start centers in elementary schools to make sure someone is present that can speak on behalf of families when they have IEP meetings or 504 meetings, that there's someone that can consult with teachers or with the deans or the behavioral specialists about how is trauma exposure actually impacting the behaviors that you're seeing. So this isn't disruptive behavior. This is actually a kid who's experiencing the effects of trauma, and it's showing up looking like maladaptive behavior or looking like ADHD, which are 2 of the key things that we often get calls for when we're talking about why teachers need support for students. And so what can we actually learn? What can you all do as providers, as Head Start directors, as teachers who are actually working with these families, and also as researchers? So we again implemented this program using a prevention framework or a prevention model, and knowing why it was important to start at this early age. So a big question I often get is, why are you all targeting specifically this early childhood population, or kids between the ages of birth to 5? And why is a lot of your programming specifically centered around that demographic? Well, one of the key things being that we know what this looks like long-term, right? So all of these different areas listed here: emotional responses, physical health, relationships, behavior, learning. So when kids are exposed to trauma, even by the age of 5, they start to show signs of negative development across these different areas. And without any intervention, you see these same patterns of maladaptive behavior, but again, it increases in intensity and frequency or severity. And so again, we're using a prevention model in which we're trying to utilize intervention models or perspectives to be able to decrease the frequency and severity of a lot of these issues. And then kind of, why is the work important? So why is it important for everyone that works with younger children in particular to be able to be more trauma informed? One of the things that we know, when you're more trauma informed, when you have a better understanding about the impact of trauma exposure, you're able to link kids to resources more at an earlier time frame. So when we look at the rate or the time frame in which Head Start centers in particular connect families to trainings, we're able to see, just looking at our Safe First Steps partners that have worked with us for 2 years versus a few months, is that the longer you work with us and become more trauma informed and aware of the impact of trauma, there's an increase in your referral period. So for example, we have one Head Start Center in particular where the teachers have been working with us for 2 years. They're able to immediately recognize signs that a kid is dealing with trauma exposure and then connect them with a mental health provider. Versus an agency that is not very trauma informed, usually it's around a 3-month period in which they're not referring kids for services until the symptoms are very severe. I'll cover that last piece there. So just when looking at disparities, that's the other the other reason that a program such as this is really important. So again, even though we know that the rate of trauma exposure, the rate of community violence exposure is significantly higher within Black and Brown communities, we also know that the rate of service utilization and service retention is very low. So even though a lot of the kids, a lot of the families are showing signs of mental health challenges, they're not enrolling in services for a number of different reasons, whether it's stigma related to mental health treatment, a lack of resources within their community, or the only resources available are by predominantly white providers who don't really understand the stressors and the situations that are occurring within these households. And so one of the reasons that it's been really helpful for us to work with elementary schools and Head Start centers in particular is because we're going into the areas where the families feel that they're welcome, that there's actually people that care about them and understand their challenges, as opposed to going to a hospital, for example, in which they've had a lot of negative experiences. And then what happens when organizations are trauma informed? So as you all are thinking about the work that you do within your own organizations, what happens when you're actually trauma informed? So one of the big things, you routinely screen for trauma exposure. So there's a number of different screenings or assessments that are done in elementary schools, that are done in Head Start centers. There's a lot of Head Start centers where they're not actually screening for trauma. By adding in a more trauma-informed approach, you change your assessments that you do, and then you're able to support these kids earlier on. One of the other things being you add more resources. So when you're figuring out what do we request funding for, how do we allocate funding? When you're more trauma-informed, you're more likely to request funding specifically for mental health services and for the increase of programming that focuses on mental health and well-being for the entire family. And then last, when an organization is trauma informed and they understand the systems of care framework, they're more likely to use a more collaborative approach or a systems of care model in which they're creating partnerships or collaborations with all the different individuals within a child's system of care. So we've worked with a lot of Head Start centers in particular to be able to figure out what are the different providers that this family interacts with on a daily basis. How can you form a partnership with the pediatric center within your community so that we're making sure these families are making sure their mental health as well as their physical health is where it should be? Or how can you create a partnership with the elementary school so that we're making sure there's a partnership in which the kids that are in Head Start have subsequent support when they go to the elementary school? And then I believe this is the last piece that I wanted to talk about. So in working with Head Start centers within elementary schools, my entire team is very mindful that we work within academia, we work in higher education, and that we are doing research with a lot of these families, and there's a lot of hesitancy for that reason. And so a big thing that we focus on during our team meetings, during our staff meetings, is how can we actually build bridges between higher education and the community? How, as researchers, as faculty members, can we help to make sure we are taking into account all the different stressors happening within this community, that the community actually feels that we are implementing these programs with their best interest in mind, and that they are key stakeholders in the development of our programming. And so these are just a few key things that we actually make sure that we do and we really focus on. So as you all think about how do you create partnerships, how do you strengthen relationships with organizations, with families, what should you prioritize? one of the big things, again, was getting to know the community and making our parents and our Head Start directors and our Head Start teachers key stakeholders in all of our programming. So we do program evaluation every 3 months or quarterly. We have a team of people from the community. We have parents, we have grandparents, we have Head Start directors who are all a part of those meetings. So making sure that they have a say in what we're actually doing to support them. And then that last piece, staying engaged with partners long-term. So again, once we establish a partnership with the Head Start Center, with the school, there are long-term partners. So as long as they would like to partner with our organization. And we're very flexible in terms of making adjustments to our program based on the needs of each individual center. So the last thing that I'll share, the QR code that you can scan here links to our program information and our action plan. So similar to how we have created an action plan for all of the partners that we work with, you all are welcome to complete an action plan just based on your own organization. And then you'll be able to enter information about what are your own goals for being more trauma informed, if there's any resources that you would like our center to provide, and any additional support. Is it? Okay. I will update that. Okay. All right. That is everything. So thank you very much. I believe we left time for questions.
We appreciate that. I will take moderator privilege to ask the first question. I also want to say that I know that some of the agendas have us ending at 2:30, but we do know that the next session starts at 3, so we do have some time to engage with Dr. Gibson. So one of the things that stood out for me from the very beginning, you talked about Bronfenbrenner's model, and I know a lot of us are familiar with that model. And so I think what I run into a lot of times with programs like yours that are super comprehensive, address all of these different things. Every question that I was coming up with, you like addressed it a slide or two later. I was like, well, they got that covered. But when you look at that model, what it appears to me is that the further you get out from the center, the more difficult the work becomes. And so one question I have is, do you all have, in that light, have any relationships with public safety and law enforcement? Because so much of what you're doing in one sense can be thought about as downstream. Like, I know you're doing a lot of prevention work, but you're doing all of this stuff in response to an environment that is violent and toxic. And there's all these systemic forces that are creating the conditions in which you all have to respond with a program that's effective. So what does that look like if you all have, addressed that? There you go.
Yeah. Thank you for that question. So I would say we definitely have that built into a lot of the programming that we do for older children and adolescents in particular. And we kind of take Bronfenbrenner's initial model, and then we also look at the socio-ecological model for violence. And so similar to what you're saying, we start with that initial kind of smaller, what's happening within the family context, within the community context, and then we look at the broader societal context. And so in addition to the work that we do, so a lot of the work I talked about here, all of the work is within early childhood populations, but we also have a community program that I work with the University of Illinois Chicago on, that is specifically about that societal piece, in which we partner with law enforcement. And so we're partnering with, we piloted a program with the Park Forest Police Department in particular, where we trained all of their officers on being more trauma informed, similar to a lot of the work that we do with our teachers here. And we've kind of expanded that, most recently training Urbana, Illinois, and Champaign, Illinois, and Kankakee. But definitely looking at a societal approach in which we train law enforcement. We've been able to do a lot of community events where we engage law enforcement, we engage the different mental health providers. And then we've also worked with a lot of aldermen or alderwomen in the community. So within the city of Chicago in particular, the Head Start centers that were in the areas that had the highest levels of crime. We met with some of the aldermen in that area to talk about what are some of the things that you can actually take to your meetings in terms of talking about how are you allocating funding within this community or within this city. Yeah, for our clinical staff, we did trainings for them in trauma-focused CBT or cognitive-focused cognitive behavioral therapy, being a more long-term model or level of intervention. We also did a lot of work with them on the child and family traumatic stress intervention, which is more short-term. But specifically being able to work with them to say, how can you implement a model within 5 or so weeks that can support these children? So yeah, we did trauma-informed trainings for them on the application of interventions. Yes. Yes, so we do a lot of different within our trainings for law enforcement, training for our deans or security officers at schools. We do a lot of training and intervention around just initial thoughts that you have, whether it's even kind of an unconscious thought. Why do you have those thoughts? And then trying to really help them look at things from the perspective of the families or the youth that they're working with. And I think that means a lot of uncomfortable conversations. So we have had a lot of conversations with police chiefs and the youth service officers at organizations about just the long-term history of Black families with law enforcement, for example. And so why it's not necessarily realistic to expect that when you come into contact with the Black youth, you're going to have a positive experience. Kind of what are all the different layers underneath that? And so that's been one of the big reasons that we've tried to do more community-based events in which all of the different people are present. And then a lot of Head Start centers that we partner with have also tried to have more activities where they do events with first responders, for example, and introduce those to them to children. But we are, I would say, very mindful of just the history of law enforcement and police within the Black community. It's really interesting when we've partnered with a few different organizations in which the staff is predominantly white, for example. And we, within our trainings for staff, we always do an activity where they have to identify risk and protective factors for the families that they work with. Almost 80 or 90% of the time, the agencies in which the teachers or the providers are predominantly white, law enforcement is listed as a protective factor and something that increases safety. It has never been listed with our sites where the staff are predominantly Black. Shocker, right? So it's very, very interesting. And those are conversations that I think a lot of Head Start directors and principals appreciate us coming in and having those conversations because I think they can't. But we do a lot of work around racial and historical trauma, systemic inequity, and why, just looking at kind of the idea of Maslow's hierarchy of needs and why you can't talk about recovery and resiliency without talking about systemic oppression and what it means that within the city of Chicago, there's this huge allocation of resources on the north side, but it's not true for the Black and brown families on the west side and south side. So we definitely have those conversations. I would say within using the city of Chicago, for example, I think it has definitely spread drastically in recent years. And so that's why I think there's been a lot more attention and funding to it, because I think it's reaching a lot of communities who initially thought they were pretty safe and that it wasn't an issue. But I think for the longest time when we first started this program, when I first wanted to talk about community violence exposure, it was kind of like, well, this is the thing that's happening within this smaller community. As it kind of branched out and was impacting a lot more children, as a lot of the white parents in some of our neighborhoods did not feel as safe, there were more people saying, hey, can you bring this program here? There's this huge need. So I think definitely as it's spread, I think that's been one of the reasons that it's gotten more attention. Yeah, so we do a lot of our, well, to answer your first question, so showing signs of psychopathology is maybe what I mentioned. I think for the most part, very few of our parents are actually in treatment or have ever been in any type of formal treatment where they were evaluated themselves. And so very few actually have a diagnosis. Just in our talks or conversations with them, doing workshops, doing focus groups, it's very clear a large percentage have symptoms of PTSD, have depression or anxiety. And so in a lot of our parent workshops, we do a lot of work that is specifically around parenting practices. And then the other side of that is the work that we do that's specifically around parental stress, parental mental health and well-being. And in working with our Head Start centers, so a key job is connecting the children to resources or services. But we've also worked with each of our centers or schools to be able to provide a list of providers specifically for adults or for caregivers. And so making sure that in addition to providing parents with a list of services for child and adolescent agencies, that we also have a list of services for them, taking into account kind of financial things, healthcare access, and things such as that. But definitely we try to make sure that we're also addressing the parental mental health piece. I think one of the big things is that I think you can have, let's say everyone in this room, I think your understanding of the definition of trauma, what it means to be trauma informed, and what trauma informed care means is different. And so I think a big thing that I see, I think within Head Start and other organizations, or even within the state of Illinois, they have new requirements or mandates. And the main thing is training. Training with the idea that we're going to implement this mandate so that you become more trauma informed. It rarely actually talks about putting it into practice. And so that's one of the, where I think there's a deficit in that new mandate or that new requirement or expectation, is that yes, you get trained, yes, you have the knowledge, but are you actually going to put it into practice? So we've worked with one school in particular where maybe 90% of the kids have trauma exposure. The teacher's awareness level is very high, right? So they understand, what does it mean that Johnny's mom was killed? What does that look like in terms of his behavior now? Are they actually implementing something to help support Johnny? No, right? So we'll do trainings and a teacher will say, okay, I understand because his mom was killed. He's really upset. His emotions are all over the place, but you're still sending Johnny to the dean, or you're still putting him in timeout. No one's actually being intentional about checking in with Johnny throughout the day. So I think that's the more comprehensive piece that is needed, is that in addition to requiring more training, is that you're making sure you're actually giving these Head Start centers the tools to be able to kind of consistently implement what they're learning in the trainings. Related to use of ecological momentary assessment. I think something that was interesting, I didn't cover it, but in doing ecological momentary assessment, we had a compliance rate of 85% with our families. When we had initially went to the different Head Start centers and said, we want to do this study or this project where we have them track it, every director said, there's no way you're going to get these parents to do this consistently over time. And so we really worked on engaging families, rapport building, making sure they actually had an understanding of why we were doing this. And I think that really helped with their engagement. And then in doing ecological momentary assessment, I think the parents knew, okay, once you work with us and you gather this information, what are you going to do with it? And so we made it very clear, we're going to work with you to track this over to a 2-year period or a few months. And then based on that, we're going to meet with the directors and talk about what services do you all need? Or we're going to work with the funders within your district to talk about what resources are needed. And so I think that's how we were able to be pretty successful in terms of family participation in that study and that project in particular, is that they knew kind of what we were planning to do with the data and the reasons that we were collecting it. And then I think the last piece, in addition to doing ecological momentary assessment, all of our parents participated in a focus group. And so I think understanding that they could tell their story beyond just kind of clicking a few buttons on the phone was really important. So they knew that we would really want to hear their full story to have a better understanding about their experiences. Okay.